Welcome to the podcast of HemaSphere, the official journal of the European Hematology Association. HemaSphere's podcast presents insightful, expert discussions about recent hematology publications. We hope you enjoy.
Welcome to this episode of the HemaSphere podcast. My name is Stephen Hibbs, and I'm a hematologist and clinical research fellow based at Queen Mary University of London, and I'm one of the scientific editors for HemaSphere. So today I'm joined by Francesca Fioretta and Helen Papadaki, hematologists based in Italy and Crete, respectively. And they're the first and last author on the European guidelines on diagnosis and management of neutropenia in adults and children, published in April in HemaSphere. So today we're going to hear about the story of this guideline, current practices in neutropenia workup and where there's significant variation. We're going to hear about neutropenia in people with DARK1 polymorphisms and how we approach that, areas of controversy, and finally where they see the greatest potential for future research. So thank you both so much for joining me today. Perhaps I'm going to start off by asking Francesca this question. Could you tell me a bit about where the story of this guideline started? How did it first get going? How did you get involved? And how long did it take to reach the finished piece?
Okay, good morning, good evening, everybody. My name is Francesca Fioretta, and I am a pediatric oncologist and hematologist in Italy. Giannina Gaslini Institution, and I've been involved in neutropenia since 2000. The project is a great idea of a joint venture between an European project, INOCRON, with the AHA, and the true engine of this project is Helen, my dear friend, and together we planned to try to write something that everybody knows or does not know, but that would argue to have written. And so it began at the beginning of 2021, and it lasted almost 2 years.
And can I ask, sort of along the way, perhaps I'll ask this to Helen first, along the way of this kind of 2-year process, was there anything that surprised you from that initial starting out to the finished piece?
Yeah, actually, yes. I think that during this 2 years journey, although I am really focused on neutropenias many years now, I realized that I learned how to better investigate these patients, and I really enjoyed the collaboration with the pediatricians. I'm actually treat adults, and I always had in my mind that concept that, neutropenia in adults, for example, is a matter of acquired neutropenia. However, during this long way, I realized that this is not the case. I have learned how to better use some diagnostic tools, such as the genetic testing and molecular testing, and I realized that you can diagnose patients with genetically based neutropenia in adulthood. So I also learned how to better appreciate the family history. For example, traditionally, when we see patients with neutropenia in adulthood, we always ask, well, when did it start? And do you have any other family members to have neutropenia? And if they say no, we go further. However, I learned that it is very important to insist on the family history and ask if you have other members in the family with infections, with early death, with miscarriages, etc. So I actually, to summarize, I enjoyed this interaction with the pediatricians, pediatric hematologists, and I now have learned how to better diagnose patients with congenital neutropenias that present in adulthood. And I think vice versa. I think that also pediatricians learned how to diagnose children with acquired neutropenias.
If I can add, it was really a challenge to try to put together the different expertise in the field of pediatrics and hematology of adulthood, but it was a great richness to have found a kind of communication that it is not so easy all the people that you have meet on your way. But with Alan was possible, and it was really possible to exchange, for example, for us, for a pediatrician, how to catch some element they may be useful to manage the patient that grown up, and how to manage the disease in adult age. And so this is really an important thing. My previous experience was in the field in pediatrics in neutropenia in the Italian guidelines, but at that time we were only pediatrician, and was something new for me and for us. And
it's interesting, isn't it, how these things often happen in silos, and you get kind of patches of expertise, but the groups kind of almost have these two completely, well, they're not completely different, but they're quite different practices, and then suddenly you bring together and you think, oh, hang on a minute, like actually there's quite a lot that you're doing that makes sense in my context too, and that's really inspiring to hear. Actually,
it is really dependent on how you want to be open-minded, because it is not always possible. Okay.
So I'd be interested to know, you made a lot of recommendations within the guidelines, and you mentioned that there's a lot of variation between clinical practice in different regions, between different clinicians. Is there anything in particular, or a few things that jump out as the things you think most need to be standardized to improve patient care in the workup and management of neutropenia?
What we realized, because we worked as a group of experts, however, before that, we had a very broad collaboration within this cost action, the unit Inocron action, where we had the chance to collaborate with pediatricians, with hematologists from different parts of Europe and beyond. And there we realized that although we were, let's say, people that are focused on neutropenias, however, we have absolutely different approaches in different areas. And, this depends on what kind of diagnostic tools you have available, what are the local practices, what is the experience of the physicians. So we had this this kind of collaboration with other people, and we realized that what we think as a standard, in specialized centers, it's not the case in other parts of the world. For example, the genetic testing, which is so important, not only for the diagnosis of specific types of neutropenias, but also to have a very follow-up, the appropriate follow-up in these patients is not the case in many parts of Europe. So, of course, we need to have a more widely available genetic testing in as many countries as possible. Another issue is the anti-neutrophil antibody testing, which is very important to characterize some types of neutropenias, the autoimmune neutropenias, which are very common in children, but also they can be found in adults. However, that the test for anti-neutrophil antibody is so difficult to be standardized. So we have to make available the genetic testing. We have to make, more friendly use the anti-neutrophil antibody testing. And of course, we have other needs, such as the better diagnosis of some telomeropathies, which may be the case not only in children and adults. So these are some examples that how some very important tests are not widely available, and how there is actually a need to make them available and widely used.
Yes, thank you, Helen. Francesca, is there anything else?
Yes, I think that the point raises from Helena are right. The tools, for example, that everybody of us have in order to face the diagnosis is very important. Not all the countries have the tools to manage diagnosis of neutropenia. So we tried also to start with the minimal effort, minimal tools to try to have diagnosis of these disorders. And another idea is that any of us probably started from different point, but we tried in any way to overcome the differences and the obstacles in order to reach a consensus. And if I can say that the phases of consensus were not so easy for this reason, because we needed the time to explain our methods, our reason. At the end, we catch some useful things from one to others. So the process was not so smooth at the beginning, but at the end, we were able to reach some consensus also on some tools, for example, genetics that may be available in one country more easily and in another country less easily, and so on. But it was at the end quite useful for everybody, I think.
Thank you. Yeah, and we'll explore about the sort of consensus and where there's still some controversy, perhaps in a little bit. I just want to move on to another area first, which is about patients who have DARK1 polymorphism. So the Duffy antigen receptor for chemokines 1 polymorphisms, which, as I understand it, is the main reasons why a lot of people who are of Black African heritage, or some people from Arab heritage, or a few other ethnicities, have lower circulating neutrophil counts than others, and why the reference ranges may not make sense for all populations. This seems to be a really important area to get some clarity on. And I just wonder, how did you approach that in the guideline, and what work do you think needs to be done to really have neutrophil approach to neutropenia that makes sense for patients with this polymorphism?
It's not, yes, that this Duffy antigen polymorphism results in, let's say, kind of neutropenia that used to be called ethnic neutropenia. However, we have avoided to use this term in order not to, to characterize this variation based on the ethnic variations. But we tried to introduce a new term, which is ADAN, which means ADC, which is the gene, dark associated neutropenia. So to be focused on the polymorphism, which, as you said, is very common in some parts of the world. However, we have realized that this type of neutropenia may be also found in not the traditional parts of the world, but can be also found in Europe, for example. And this is reasonable because, people are moving around, and also, we have marriages between people. For example, we have identified this type of neutropenia in our cohort of patients in Greece. And we have a cohort of neutropenia patients, not only from Greece, but also from Balkan countries. And we have identified 5% of the population, which are not traditionally originate from Africa or Middle East, but are Europeans that present this polymorphism. So what we have introduced in these guidelines is that we have to insist on investigating, on exploring the presence of this polymorphism. And if we do not have access to the genetic testing, which is very simple because you just perform a PCR analysis to identify the polymorphism, but if you cannot do that, at least you can make the phenotype of the red blood cells and identify these DAP-null phenotypes, which are associated with this type of neutropenia. So it's not actually the limit of the neutrophils that makes you to have the suspicion of this type of neutropenia, and just perform the phenotype and, of course, if you can, the genotype to identify this polymorphism.
Can I ask then, if you did do that and you found someone had the polymorphism, what would be your next steps? Because I guess that do we have reference ranges yet? Do we have ways that we can approach that? Or how would, if we don't have them, how do you approach someone who's got a low neutrophil count, but is it because of the polymorphism, or is it too low for that? Those are the sort of questions that I think people perhaps often grapple with.
This topic is quite intriguing because this characteristic found on red blood cell and the link with neutropenia is important in order to define a disorder or a non-disorder. So the risk is to medicalize a lot, for example, children or even adults that carry this type of characteristic. And one of the goal even of the guideline was trying to lighten as much as possible the controls of in person in which who are not really needed all this stuff. And also the consideration of the threshold of the neutrophils probably will change it as considering, for example, patient being treating with the chemotherapy or some or other kind of treatment. And so it is really intriguing, and surely we'll need more step forward in order to identify what kind of patient are the carrier of this characteristic. Also, we are going to observe that a number of Caucasian are the final according to the characteristic, and so I think we must deepen and enlarge the cohort in order to have a better idea on how it works and how we can manage all these things.
Helen, is there anything else you'd say about your approach to patients who've got a polymorphism of the dark gene?
Yes, we actually relax when we identified such patients, because there is no need to proceed further to have, the bone marrow aspiration, etc., which, well, it's not a pleasant exam to perform. Of course, we have a follow-up in these patients, particularly if the white blood cell counts are lower than those that you expect in such types of neutropenia. However, at least you do not need to perform, this exhaustive investigation that you have when you perform when you have this otherwise identified neutropenias.
And just sticking with you for a moment, Helen, Francesca spoke a little bit to this point, but just interested to hear about where there were areas that were harder to find agreement of in this process, because your guideline process, I think you needed 75% consensus to agree on a recommendation. Were there any areas that you just couldn't find agreement on and you had to sort of set aside as a recommendation, or were there others that it was quite difficult to reach a consensus because of differences in opinion within the writers?
It was so nice. It was a so nice procedure, because it was not easy, because in all topics, in all recommendations, we had many rounds of discussions. And of course, there were some areas such as, for example, what are the levels of investigation, what type of investigation should be included in each level of investigation, because we have the first approach, the second approach, and then you perform the bone marrow, etc. So yes, given that we have children and adults, and we had decided that both should be included in these guidelines, we have many rounds in this particular area, which should be the investigation that should be included in each level. Also, we discussed a lot about how often we should perform bone marrow aspiration in congenital neutropenia patients that come to the adulthood. Where there you have people that want to get married, they have their first relationship, etc., and they do not want to, to be in touch with their doctor. So these particular patients that move from the childhood to the adulthood, and now they live normal because we have, GCSF, etc. Because in the past, these children, they didn't live a lot because of the infections, etc., because of acute myeloid leukemia, etc. But now these people live as the rest of the population. So we have these, young adults that need specific approach. So we had this kind of discussion. However, for me, it was the best experience because this kind of discussions between people that are experts in their own field, it was so didactic for each of us and so educational, etc. That we really enjoyed. And finally, we had a broad consensus in all topics. But we had, of course, many rounds of discussion as well.
And if I can add, the percentage, the lower percentage of consensus were related to news, to something new. For example, I went through the percentage and I realized that, for example, the ADAN, the new definition of the ethnic neutropenia, was really difficult to be defined as ADAN is now, because probably new way of considering things are difficult to be accepted at the end. And also, we had a lot of discussion on classification in relationship with this new provisionally acquired, likely acquired neutropenia, which seem promising to describe and to connect those neutropenia that rise in infancy and goes on without remission since adulthood. And so this is really an interesting field, and it is also a matter of collaboration with, for me, with the adult world. And also, I confirm the concept of the frequency of controls. It was a matter really of discussion, because as pediatrician, we are in a habit to do more frequently some procedures, because sometimes parents ask some answers, and in adulthood, a neutropenic patient learns how to live, how to manage, and he has or she has a lot of things to do and does not have the time, or doesn't want to have the time to check her or his bone marrow. And so it was quite a challenge.
So final question for you both, and I'll start with Francesca's answer on this one. If you could have a ridiculous amount of money, let's say £1 billion grant, €1 billion grant, you could have access to the data of every neutropenic patient, adults and children around the world. What would be the most important uncertainty in this field that you would want to answer? So Francesca, I'll start with you on that.
My dream is try to understand what kind of neutropenic patients are really neutropenic or not. So I explained sometimes I believe that some patients without any symptoms are not neutropenic, but their neutrophils are in some other places other than within the vessels. And I would like so much to try to follow the neutrophils and try to understand where he's going to need to hide. And this is something that would help us to consider a person with a disease or without a disease. And this is true not only for the ethnicity, but I think for other kind of genetic characteristic probably that active or inhibits some, for example, receptors that can allow the neutrophils to go in other places other than the vessels.
Thank you. What about you, Helen?
I totally agree with Francesca. In neutropenias, you have a picture of the neutrophils that circulate, and however, there are neutrophils everywhere in the body. You have neutrophils in the bone marrow. You have neutrophils in the tissues. So we call neutropenic some patients, and they are not ill. They just have their neutrophils somewhere else in the body. So I totally agree with Francesca. And also for me, it's a challenge to further investigate these idiopathic patients as well, because you have the patient, you perform a number of investigation and exams, and finally you say, well, in 60% of these don't say patients, of these people, you do not identify anything. However, if neutropenia is there, so I would like to perform a whole exome analysis in every neutropenia patients, because as far and as deeper you investigate these patients, you identify some, variations, and then it would be very interesting, to join data from different databases and to see if other people in other labs, other areas, etc., display the same variation that you identify. So the whole exome sequencing for me would be, I would like to perform it in every idiopathic neutropenia patient, because I believe that some of these patients have congenital disease that has not been identified, not traditional congenital neutropenias, but some variations that result in the neutropenia. And also another challenge for me is to further investigate these variants of unknown significance that we identified in our genetic testing. And it would be very interesting, again, to combine data and also to perform functional analysis to identify which of these VUS or variants of unknown significance are pathogenic in these patients. So these are my, research dreams and experimental dreams in the field.
Thank you so much, Helen. Thank you so much, Francesca. Your time and expertise is really valuable, and I'm grateful to you both joining us this morning.
Thank you so much for your time. Thank you indeed.
It was really a pleasure to have this dialogue.
Thank you. Thank you both. And thanks to all our listeners for listening in. Please do check out the guideline itself, where you can learn a lot more about neutropenia, its management, its definitions, and the uncertainties that remain. And we'll be back soon with another episode of the HemaSphere podcast.
Thank you for listening to this episode of the HemaSphere podcast. All of HemaSphere's content is open access and can be found at www.hemaspherejournal.com. We hope you will join us for future podcast episodes.